Got it. Great. So I have nothing to disclose. And then here's our learning objectives. So basically, I'm going to start by talking about some things that are important to really be conscious of, including like how your own experiences and biases can affect persons with mental health conditions, whether they're conscious or unconscious. We're going to talk about using non-stigmatizing language because that's really important when you're working with persons with mental health conditions. We'll talk briefly about the ORs. Those are some of the skills that are part of motivational interviewing. And the last thing I want to talk about is shared decision-making. Because one thing that's really important to know about this population in general is they really like to have choices and get to make decisions about their care. And so it's really important to use shared decision-making with this population. So we're going to start by examining personal experiences and biases. So one thing that's really important to realize is in many of the professions in the behavioral health world, as part of your training, sometimes they recommend that you do your own therapy and do your own work. Pharmacy doesn't do that. I'm not aware of any psychiatric pharmacy residents that make you do therapy. But why it's important is to really be able to have a good understanding about like your own experiences, feelings, and beliefs, and how that could impact either consciously or unconsciously, how you interact with persons with mental health disorders. And so what kind of consists of that is if you're a person with lived experience. So you've had your own mental health issues, including, and when I say mental health, I mean substance use disorders like too. It could be that you've had family or close friends have mental health issues. And for some people, that may have been a real struggle for them. And because sometimes that can negatively impact family and friends. And that may be some bias that you may have just because of that experience. Associates, lots of media portrayals we know that are out there that are not always positive, stereotypes, and a lot of stigma. Now, couple that with the fact that it can vary depending upon the mental health condition. So I think depression and anxiety in general is much more socially acceptable these days than it used to in the past. Whereas I think disorders like schizophrenia, bipolar disorder are still seen a little differently because I think most people probably personally know someone, if not themselves, as having depression or anxiety, but they may not know someone or really have interacted with someone who's a friend or family member with a serious mental illness. So just things to keep in mind. Now, the other thing, if you've never taken any kind of implicit bias test, I think it's really important to do that. So the Harvard Implicit Association tests, IATs, are very well known. And what they do is basically you take this test and you're basically clicking and choosing different things. And so what it does is it assesses for implicit biases that you may not even be aware of. So biases that are unconscious. And they have ones for health, mental and physical. And so what I've done is I've done the link to the mental health ones because a lot of times people go to the other ones and they don't know the mental health ones exist. And so there's a variety of tests. And I think a lot of times when I've asked students to do this or residents or other trainees, sometimes they're surprised by what they find because they're like, I had no idea I felt this way. I took the one for mental health and it was really interesting. I thought I'd be neutral. I was actually more biased toward persons with mental health versus those who didn't have mental health issues. And I think that probably came about because I'd been in practice for so long. But a lot of times the results are surprising because you don't know kind of what's happening with your unconscious biases. But just being aware of those things, I think really helps when you're interacting with persons with mental health disorders. And I like this cartoon because you can see this person, you know, we have this big sign, you know, if you have any questions or concerns, let us know. And there's a patient there saying, hey, I have questions. And this person's like, don't ask me any questions. Don't ask me any questions. And you can just imagine that this patient probably is picking up on that, right? That, yeah, you say you want questions, but you really look like you don't want to answer any of my questions. And so we have to be aware of kind of those body language things or the things we don't say to patients that they can pick up on, because that can impact our relationships that we establish with patients. Okay, so any questions about biases or personal experiences? Okay, so next we're going to move on to non-stigmatizing language. And one thing to keep in mind is what's acceptable language in behavioral health constantly changes. So if you stay in the field long enough, terms that used to even be part of diagnoses are no longer okay to use. And so it's important to stay up to date with that and make sure that you're using patient-centered language. So one thing is I really hate the word normal. And when I got my psychology degree, we had a class called abnormal psychology. Like, you know, like there's something wrong with you over here. But just remember, normal is just the setting on the dryer. So no, really, none of us are normal, although some people may think they are. But really, the way to look at it is mental health is really a continuum. On one side, you have serious illness. On one side, you have someone who has perfect wellness. And for most of us, we don't live at either end of the extreme, but we live somewhere on the spectrum. And where we're at on the spectrum can change at times, right? So sometimes we're doing really well, but then maybe we have something happen. Maybe we lose a job or, you know, we get some bad news and that impacts our wellness. Same for persons with mental health conditions, including serious mental illness. So I think like one of the misnomers out there is if you have schizophrenia, you know, you're not going to be able to do anything in life and, you know, you're not going to work or go to school. And that's not true. So even a person with serious mental illness, if they receive effective treatment, the earlier the better. Actually, you can see patients with schizophrenia also go into remission and recovery. And that's a really important thing to realize, that people do get better. And mental illness isn't kind of like this bad thing that's going to necessarily negatively impact you. And that's why if you have the opportunity to work with like peer support specialists, persons, I think Steve mentioned that with lived experience. And that's like some of the, I always think that people experiences and have recovered from them are some of the best people to work in this field because you really are able to relate and have a lot of empathy because you've gone through your own struggles. I need to look at my screen more, I think. Okay, so stigma has been a huge passion of mine for a long time. And so I try to make sure to impart this on trainees or anytime I present. I try to throw stigma into like presentations whenever possible, unless it's really odd, it looks strange that I put it in there. And you'll see like early on, I was saying things like we shouldn't have any icks, right? No schizophrenics, no alcoholics, no diabetics, no icks at all. Because an important thing to remember is patients are people with diseases. They're not diseased people. And I think sometimes it's easy for us to say things like our diabetes patient, our depressed patient. But then what it really does is it basically implies that that's all that person's about, is they're just a depressed patient. But a person who has depression means there's more to them than just that disease. And so, yeah, it adds a few extra words to what we have to say every time, but you want to start training yourself to always say about your patients. And it's always preferred to call them a person because, yeah, they're a patient to you, but that's not all they are, right? They're a person who has this whole other life besides just their disease state. So you want to start practicing that. Person with schizophrenia, person with diabetes, and that goes across. You want to do that for everybody, so that way you're just naturally doing it when you're talking about persons with mental health disorders. So, because I'm really, like I said, I'm really passionate about this, and I was really excited. This article came out right when I started at USC from Pharmacy Today. And it was focused on the work of Kelly Gable, who's a psych pharmacist. But then I was also so excited that they put some of the things that I talk about all the time. So the other thing is really avoid slang terms. So you want to start eliminating those from your vocabulary when describing people. And that's something I think we casually slip into conversation. I do it when I refer to things that aren't persons with mental health disorders, and I try not to because it's so easy then to just let that slip in your other conversations. Always think about your tone and how that's coming across to patients, the body language. Because if you think about it, if you're in the pharmacy and a patient comes in and and sometimes you don't even realize you're doing it, but you may take a step back. what does that communicate to the patient that you're taking a step back from them? And so you want to be aware of everything you're doing, not just your words, but also your nonverbal cues as well. And then the other thing is when you talk about a person with mental health disorders, and some people really hate the word behavioral health because they're like, it's a mental illness, it's not behaviors. But really make sure when you're using words to describe a person who has a mental health disorder, you're always describing the behavior. You're not saying it about the person themselves, right? Because once again, the person is not all about their illness and all of that. We always want to make sure that they're a person first. So then I was excited because I saw the Huffington Post. They had a whole thing that said, we need to stop using these phrases when we talk in the news as well and write articles. And so this is really starting to spread right now. And I really like this table they had in their article that said, instead of saying this is what you should be saying. And once again, remember this continually changes and it doesn't stay the same. So what's acceptable now, what we may decide in 10 years, it's not the best word anymore. So this is another good reference to kind of start thinking about how you're using your language. So no mental health slang. Like I said, you want to start eliminating that from your vocabulary. Another thing, pharmacists tend to, depending who you are, my residents do it all the time. They use the word compliance versus adherence when they talk about medication. And the thing and I really like this article because they talked about what's the difference between compliance and adherence. And really what compliance is the patient's doing what you want them to do versus adherence really has the connotation that you're making these decisions together. And emphasizes that the patient has a choice and, versus they're being disobedient or a bad patient because they didn't do what you wanted them to do. So the only time that you really should use the term medication compliance is if you have a patient who's court ordered to take treatment, because they are required to take the medication. But all the rest of our patients, and not just persons with mental health disorders, for the most part, patients don't have to do it. It's a decision they make. So that's why it's adherence and not medication compliance. So questions about the stigmatizing language. I could talk like a whole hour on that alone. Okay, so I'm going to talk about the OR skills, and I'm going to talk specifically about why they're so important for persons with mental illness to make sure that you're using these skills. So the first one is open-ended questions. And so once again, and why this is really important is persons with mental health issues may have had some experiences where they feel like people didn't want to listen to their story. There's lots of things I've heard over the years about, a patient goes in to like the emergency room for something. And the minute that the provider finds out they have a mental health illness, it's kind of like, get out, they don't say that, but their whole kind of disposition changes. And so patients are really used to being shut down sometimes. No one wants to hear what they're saying. And so if you allow your patient to talk to you about what's going on, it really helps build that rapport. And all of a sudden they're like, wow, this pharmacist really wants to listen to me. And that makes that connection. And it's really important to a person with mental health disorders who may have not had that experience where everyone just they're uncomfortable and they just want them to leave their setting. So make sure you're using those open-ended questions. Affirmations are really important because having mental health mental health disorders is not easy, right? And it's hard to change things. So like, for example, if you're a person who has depression and you've had one way of thinking about things for a long time, where you think like negative thinking, and now you're trying to change your thoughts to be positive. I don't know if anybody's tried that, but it's really hard to change how you think. And I always describe it to patients. It's like you have like a gravel road and you have a rut, and that's kind of what your brain does. So it automatically just wants to go down that road. And now it's like you have to build this whole new road in your brain. And so that's why it's important to really acknowledge when the patient is struggling, trying to make changes, or when they're being successful, you really make sure that they know, that they've made this effort. The one thing is just make sure they always sound genuine, because patients really pick up on it. If it sounds like you're just kind of saying it because you think you should say it versus you really feel that. but it is really important to give your patients those affirmations so they know they're doing a good job. So I think an affirmation, at least one every time you meet with them, even if it's something really small, I'm really, something like, I appreciate how hard it, how much effort you made to come to the office today. Because sometimes that can be challenging, right? With transportation. And they have the patients I've worked with usually have 100 things going on in their life too, that can sometimes make circumstances chaotic. So the fact they even made it in is a positive. Reflective listening. This is such a valuable skill because remember, these are patients that typically feel like they've not been listened to by some providers. And so when you actually reflect back what you hear, they're like, wow, that pharmacist really gets me. They really understand how I feel. Or, and sometimes I get it wrong with my patients. I think I heard one thing, or I thought they had a feeling. They're like, oh no, it's actually not like that. It's this. And then they correct that. And that's helpful because then the patient has that opportunity to tell you that, no, this is really what I'm trying to tell you or what I said. And that continues to build that bridge. And so that's a really important skill as well. All these are important. Summaries, and those are really good to begin and end appointments. One challenge that you may have, and you may have experienced this in your clinics, is sometimes a person with a mental health disorder can have symptoms that can make conversations difficult. So for example, if you've ever worked with a patient who's in an acute manic episode and they have, rapid pressured speech. I'm looking at David because I know he's probably had this experience. And, you're there and, the patient's like talking straight for 20 minutes, you can't get a word in. But then you can have patients who, once they realize that you are a good person to talk to, they're going to want to talk to you. And so I like summaries. I especially like to begin and end my appointments with summaries. Usually what I do at the beginning is I will just summarize what we talked about last time and what they were supposed to do before they came back, because then it reminds us all what we were supposed to do. And then the patient's like, wow, she remembers what we talked about, even though I probably read it in the chart, what I wrote in my last note, but it makes the patient feel important, that they really matter to you. And then I do it at the end because I want to make sure we've captured everything and that the patient understands what the next step to do is. And I hear what they're willing to do or not. And once again, it shows the patient that you're really listening to them and they're important to you, because once again, they may have not felt important to other providers. And like I told you, my patients have always loved pharmacists, so especially their community pharmacists. So questions about ORS, because we're going to spend more time with the shared decision-making and giving you some time to practice. Okay. Now, before I start, I want to tell you why shared decision-making is so important. Once again, I'm thinking about my patient population. So persons with mental health disorders. A lot of times they've had other people just telling them what to do, just saying this is what you have to do, or this is what you should do. And they don't have any voice, right? And so a lot of times, and patients with mental health disorders really want to be involved with their care. I'll tell you, I know Dr. King's doing her engagement session right now, but a person with mental health disorders typically is going to be one of your more engaged patient if you establish rapport with them. So once you have done that, they're going to want to engage with you and they're going to want to be part of their care. I had a resident once a number of years ago, and it was his first experience working with persons with mental illness. And, and so we touched base one day, he's like, wow, he's like, the patients have so many questions and they read all the information. I go, yep, exactly. That's what my patients do. And so they're going to want to engage and they're going to want to join with you to make decisions. They don't want someone just to tell them things. Because your knowledge is very important, but also we want to make sure our patients know what they want and what they value, prefer is also important. So here is the AHRQ share approach. And you'll see, you know, it nicely spells out the word share. And so I'm just going to go through this. I can't go into real great detail because I want you to have some time to practice. But I'm going to point out some places where I think sometimes pharmacists struggle with, or they might get it wrong as to how to do it. So the first thing is you have to ask, you have to summarize the health problem and then ask your patient to participate. And that's important too, because if you're familiar with the stages of change, sometimes patients aren't ready to engage in treatment. And as I look at it, we have tens of millions of patients with mental health disorders. And if you have someone who doesn't want to engage at all, you might want to spend more of your effort on other patients for now and then come back to that patient later. So you want to make sure that you ask them if they want to participate. And then you want to ask them, is there anyone else that you'd like to participate in your care? And they'll let you know. And the thing to remember is sometimes persons with mental health disorders have had conflict with their family members. So they may find other people who aren't their blood family, but they're their family and they want them to be part of it. And then just remind your patient that, your participation is really important because I really want to hear what you have to think about your treatment. Ding, 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 the patient's really excited now. Now you've acknowledged that what they want is what you should be doing. The next thing you want to do is find out what your patient already knows. And it's really interesting when you ask that question before you start into all your knowledge, because you'll hear some really interesting things and you'll pick up some things that may become really important because a patient may already have in their head what they want to do because they heard it from their friend, they saw it on TV. And that could be good or bad. They may be against something because they saw something on TV. I have lots of patients who have made decisions about medication based on what their friends say and the TV says. And then next thing you want to do is make a list of options and describe them in plain language. Usually what you should do is for most patients, don't just give them, because this is where pharmacists sometimes get this wrong. They think that, okay, I'm going to tell the patient this is the best medication option. And if the patient says yes, that means we did shared decision making. No, what you did is you basically, that's your plan. And you only gave the patient one option. So they may have told you yes, but they're not going to do what you said because they didn't get to choose. So I always like to do 2 to 3, usually 3, unless I have a patient who has some limited cognition because it could be they're more acutely ill. So I give them 3 options. I pick the 3 that I think are best. And then I explain the risks and benefits of all 3. Now you may really think one is better, but the patient for whatever reason may not agree with you. And it may be because of the side effects. So it may be a really great medication in terms of efficacy or effectiveness, but the patient's going to be like, no, I'm not doing that. Because I heard risperidone was such a big issue on the psych unit because my male patients were like, yeah, I'm not going to do that because I'll grow breasts. So I'm not going to do that. So like that's a patient, for example, if you give them one option, you're done. So that's why it's also important to find out right away what the patient already knows. So that way you don't put something on the list they're going to cross out immediately. Also communicate numbers. So things like some people, a little people, nobody knows what that means. My definition of some may be different than David's definition of some. So you want to use numbers whenever you can with patients and also use the teach back technique to make sure you know. Okay, so you made your list of options, you described them in plain language. I will tell you once in a while, the patient will give you a list. This is a fun story I had. So one time when I was on the acute psych unit, the psychiatrist called me and said, Lisa, I have a patient who wants a pharmacy consult. I go, okay. So I go over there and the patient was really angry because they were going to go to court and they didn't want to be court ordered to take medication. So they were really, really not happy about it. And so I said, well, what medications? So he was talking about all these medications he didn't like. And I said, well, what medications are you willing to try? So he gave me a list of 5 options and I picked one. It wasn't probably one I would have chosen, but it was the best out of the bunch and he didn't want to take anything else. And I talked to the psychiatrist and that's what we went with. So sometimes you may have a list of options from your patients that you're talking about too. Because once again, the goal is to get your patient to take a medication and be adherent so their symptoms can go into remission. So, you have to be flexible. You can't just always have your own idea and it always works that way. Okay, assess your patient's values. So that's where you're going to ask a lot of open-ended questions, find out what matters. Side effects are a huge concern for persons with mental health disorders. That's one of the #1 reasons they stop taking them. So I always ask my patients, so what side effects concern you the most? And sometimes I may ask that before I even give options, because I'm like, okay, I'm gonna cross these off because I know like risperidone is not going to work for this patient because they already told me that. And listen, and this is where you can really show that empathy. So when they are telling you about maybe something that happened to them before when they took a psych med, you can be empathetic. And you want to make sure that the patient knows that you understand their values and preferences matter. And then you're going to agree with what's important to the patient. And this is where pharmacists struggle too. So the key thing to remember is you're not agreeing that you think that their decision is the best decision, but you're agreeing that's important to the patient. They're two separate things. Because once again, it communicates to the patient that they're important and you're listening to them and you're hearing what they have to say. And then reach a decision. And for the most part, not all decisions have to be made right away. In the acute situation, yes, but most of you're not in the acute situation in an acute psych hospital. So you may want to ask the patient if they need more time to make a decision. Do you want to go home and discuss this with your spouse or whoever? Do you need any additional information? Is there any other information I can give to you? Because remember, patients are pretty savvy, right? So they're going to go on the internet and do their own research. So it's better for you to make sure they're going to reputable sites or you provide them that information, confirm the decision, then verify the next steps to be taken, and then schedule follow-up appointments. Another thing, before I forget this, because I heard this yesterday from one of my residents when they were presenting their case. So if they were kind of like, okay, shared decision-making about meds, shared decision-making about everything. So the non-pharm too, because otherwise you're giving this patient a list of like 20 things they should do for non-pharm, like eat more fruits and vegetables and exercise. And you have to do the same thing with that too, because remember, a lot of times with mental health disorders, it affects cognition. And so patients may have a hard time focusing, concentrating, remembering things. So if you get a medication and give them 15 things they have to do for non-pharm, it's probably overwhelming. They're going to forget it. So I usually talk about that and say, so out of that, what do you think you can try before our next appointment? And then they let you know how much they can do or what they think is reasonable. And once again, you give the decision back to the patient. And then there's always a plan. So the thing about the decision is it's not final. You're going to meet again and talk about how it's going, and then adjust as needed. So sometimes your patients are going to have barriers, right? They want to do something, but now they got the medication they went to, and they had a side effect. So now they're not going to take it anymore. So you're constantly, having these conversations again and again with your patients. But I'll tell you, if you've never used shared decision-making or you've used a abbreviated form or kind of a modified form that isn't quite shared decision-making, when you start using it the way it's intended, it makes a huge difference. I had a resident once, she's like, oh my gosh, I had no idea how successful this would be until she actually tried it out. And she said the patients just respond so differently when you have that process with them versus I'm just kind of saying, this is what you should do. Do you have any questions? So it works really well. So I'm going to have you practice, and this is where we're going to have to put, Lisa, Jessica, we're going to put people in breakout rooms again. So we'll do pairs or groups of 3, and you get to choose one of the following scenarios. And so what I want you to do is you'll have one person, and you'll see they're all persons, they're not patients. You'll have one person one of the attendees play the person who has the psychiatric disorder or is taking the medications. One person will be the pharmacist, and we'll practice and use shared decision-making, the OR skills, non-stigmatizing language. It's okay if you mess up. I know it's hard to change language that you've used forever. But go ahead and practice and see how these skills work for you. So we'll go ahead and do that. And then here, I think probably people can pair up too and practice the skills. So do you want to take that over to make the breakout rooms? And how much? I have about 15 minutes. So I'll let you practice for 10 minutes on skills, and you can go through more than one scenario. This is my one, right?
Yes. You're right. Oh, yeah, you're right. And
Breakouts?
no, Steve is the host.
Can Steve make the breakouts?
Stepped out.
Yeah.
She didn't know she would do it.
And for people on Zoom, we're working on getting the breakouts.
I don't think I've been on that many video classes.
I can't do Steve. Oh, can you ask him?
Yeah.
Me and my breakout sessions.
Only once.
I'm a big one's practice.
I love it.
You guys are we're just meeting for the first time.
Okay.
Yeah.
Sorry.
We'll
We'll practice. We'll practice.
Yeah, you have 5 choices.
Okay.
Person with I want to be
What, sorry.
I want to be the person with newly diagnosed with mild major depression.
All right.
Right back. Leave you all some privacy.
So are we airing for?
I mean, it's like
Yeah, we got breakout.
Yay.
Oh, you can be the pharmacist. I can be the person with the. What do I want to be? Natural. Yeah, because I don't.
Why don't we just stop this?
Yeah, I don't.
You're newly diagnosed, right?
Yeah, here to pick up, I don't know, the medication. Yeah. My doctor prescribed.
do you know why you're taking this medication? Well, you have to
It, my doctor prescribed.
Is that what they told you?
I don't know.
So. When the doctor medication, what do you tell you?
I think my doctor say I was diagnosed with something with depression. I'm not happy. I don't know. I just medication. We're gonna get pharmacy.
So do you give you any information about medication or what choices you may have? Or...
Did you say I have depression? Is that something?
I mean, is there, do you feel like depression is something you want to?
No, if you is a depression, they usually, my friends say depression is crazy. The doctor just diagnosed me with that. I'm not crazy.
That's very realistic.
So I don't know. So what are you going to give me? I don't know. Sorry, I'm giving you a hard time.
So we have this medication supposed to help you improve your mood. I'm not sure if you want to try this medication, which it may help you, but it may take some time for you to take. You have to be consistent with it. That's something you want to try, or
Am I going to be happier tomorrow?
it won't work immediately. It does take a couple weeks for it to take effect to see the real benefits.
Okay, so what do I need
What's
to
that?
do to make me happy? Other than just take medication.
Be
USC
consistent.
IT. Okay. inconsistent meaning so what are the side effects?
Side effects or
Virtually.
side effects.
So if have that side effects, do I still have option or what do I do? Because you think it's gonna take a while. So am I going to get worse?
So when you're taking medications, the circulating is going to take weeks. So the first couple weeks, it can be better, it can improve as you take it. Recommend that you have a consistent schedule for your medication, you need a toolbox, you remind you that you're taking your medication on time, or put it on the phone.
So is it going to make me stay up at night or should I take it in the morning or should I take that? Or it doesn't matter?
During the day, you know, so that you're consistent.
So if I have questions, who do I call? No, I'm trying to listen.
Okay. We can give you some pamphlets about the medication, the drug information, and then we can also give you some information about resources in your community that can help with outreach, counseling, or when you're moving to
I'll give you
that's all we got.
So how do you think it went?
Terrible.
Well, why do you say that?
Well, it's not terrible, but like I think it could be better.
Okay, so what do you think you could have done better?
Probably more open-ended questions and more affirmations, I think. Working on that. And then involve her in decisions. That's probably the one thing that
Yeah, and those are all things that are really hard to change, right? If you've been doing your practice in a certain way for so long, it's just like my example about, like depression, negative thoughts, same thing. It's like a pharmacist road in the brain. And it's like, building a new road that now is going to have you go down the path with your patient using, involving them in the decision and reflecting and asking open-ended questions. It's not something that it takes time. So don't beat yourself up.
So just question, what kind of resources do you recommend for like a retail pharmacist for training purposes?
Oh, that's a good question. So, are you looking for a resource? What kind of resource, baby?
So I have a team. I have 15 pharmacists. And they work in 2 different pharmacies. But we're part of the medical center. So I want
20 seconds? Okay.
so I need something to be able to train the individual pharmacists. Kind of like these things. Or ask questions to the
Got it. So more on the soft skills again. So AHRQ, definitely go to that because they have a lot of nice resources on shared decision making, including videos that pharmacists can watch. 'Cause I think a lot of times shared decision making is not taught in pharmacy school. This is bad. I don't even know. Well, wait, it is taught at USC because it's in my course. But I'm trying to think like, you don't normally hear. Probably not. Well, it's current now, I can tell you that, because it's in my course. But I think that's the thing is like a lot of times like those topics aren't taught in pharmacy school, right? Unless you have a faculty who's like, hey, we need to make sure we're doing this. And so AHRQ site is a really good site for shared decision making, and they have different handouts and the videos that are really great to use. Is something I would highly recommend for AHRQ. Okay, someone in the chat. Oh, that's just a thing from Jessica. So how did it go? Everyone on Zoom. Some thoughts about, was it difficult? And I can share that the in-person group found it really challenging to use some of the new skills. So how did you all feel? And you can put it in the chat, which you can't see, but I'll read it to you if there's something that comes up. Yeah, there's nothing in the chat. And I was just sharing that the group in person found it really challenging to use some of the new skills. In Zoom, oh, sorry, so that you didn't have the scenarios in front of us, so you didn't know what to practice. So what I'd recommend for anyone who is in Zoom and didn't have the scenarios in front of them, you can still practice with like your coworkers or other people. And what I'd recommend is use some of these scenarios. And I don't know if anybody noticed, but these are all those core measures. These all fit into the core measures. And so I would just practice and use these scenarios and practice different skills, because the person in each scenario can act differently each time, right? So it's a new situation every time you do it. And I was just saying too, that these skills, you're not gonna, most people can't be perfect at them overnight. It takes time, so don't beat yourself up if it takes you a little while and you're like, oh, I forgot to, give an affirmation. And I was a little too telling the patient what to do versus involving them in the decision. But I think the more mindful you are and kind of like shared decision making, you might want to just pick a few things to start with and get good at that, and then keep adding to your toolbox until you have all of those soft skills. And then someone asked like, what kind of resources would I recommend? I think the AHRQ website is really, really good for shared decision making. It has videos, and then it also has different resources too. And so it's a really great place to look at all of that as well. It was a bit challenging if the patient's not motivated and we're nonchalant. Yeah, and that's where I think it's important to recognize that is really assessing where your patient is at stages of change. Because remember, we have tens of millions of people out there who have mental health disorders, and you may have to decide which patients can I help. And so you may want to spend more time with the patients who are willing to engage with you. It also, I think, helps you feel a little bit more successful and a little more confident. And then as you build your skills, then you may want to try to re-engage some of the patients who are a little more challenging to work with at first too. The other thing I find is sometimes you have to ask more questions of those patients who appear on the surface to be unmotivated, because there's something behind that, right? There's something going on. And that's where sometimes when you ask and you figure out what the problem is, it may be something that maybe you can't help with, because it may lie kind of in the social determinants of health or other things that are going on, the psychosocial stuff. But if you kind of figure out that maybe they're not engaged with you because they're like, oh, the pharmacist gives me all these ideas and, I don't have any money to pay for anything. Those could be barriers where if those are addressed, then you might be able to get the patient to engage. Is it that time? I don't want to run into people's breaks.
Oh, you're perfect. 3:40.
Oh, wonderful.
You have 1 minute.
Okay, so just kind of a final thing. So like I said, all of this is, new for most pharmacists. Most pharmacy schools don't do a good job, or even if they include it in their curriculum, they don't do it enough where new grads feel comfortable doing the skills. But if you ever have any questions or want more information or things like that, you can always reach out to me. I don't know if I put my email on the slides, but I think it's pretty easy to get it. All right, thanks, everybody. Sure.
Yes.
Yeah, we're so lucky to know. She's like really Lisa and David, both of you guys, like your expertise is in, traditional pharmacy and what we learn in pharmacy school. And like, even if we come out doing clinical practice, it's always primary care, like MPAR focus. So it's hard to get that insight that you guys both give. And like, I think people who even work like us we shy away from it unless we have like a psych pharmacist on board. And then we give them everything because and it's what PCPs do. Like, they see mental health and then they're like, oh, I'm not touching it. Like, I can't do it. And then when those patients try to get help from
I can't hear. All right, well, welcome to our breakout that focuses on substance use in community settings. I have the pleasure of introducing Dr. David Dadimov. He's a board certified psych pharmacist and on our faculty at the USC School of Pharmacy. Completed his PharmD at University of Michigan, did his PGY1 there as well, and then PGY2 down here in San Diego. We were fortunate to recruit him to the School of Pharmacy when whole person care created positions here in Los Angeles County. This is a couple of billions of dollar program, very large price tag, where basically David was challenged with how to reduce utilization, improve outcomes for the 100,000 of the most challenging Medi-Cal in the county. I have to say he's done a remarkable job. He leads and manages a team of pharmacists that are part of the LA County Whole Person Care Program, has made tremendous connections within homeless care, incarceration, justice, and has tremendous expertise in substance use. So we're thrilled to have him here today. Thanks, David.
Thank you so much, Steve, for that wonderful introduction. And it's really a pleasure to be here and at the CRMC and speaking about substance use disorder. As Steve mentioned, this really is a passion area of mine and something that I've really been striving in my career to help bridge those gaps that a lot of these patients face when trying to access treatment. And of course, the community pharmacy is just such a major hub where that level of care actually takes place. So I don't have any financial relationships to disclose. Neither Alkermes nor Indivior are paying for me to like that. This is all evidence-based and so forth. And I should also mention that by all means, if I say anything, just feel free to interrupt me if I mention anything that needs addressing or slowing down. I've got the chat up, and so now, okay, hopefully folks can hear me fine now. Okay, great. Yeah, it's really my pleasure to discuss today our approach to patients with substance use disorders in the community setting. By the end of the session today, I hope to paint the picture of what barriers patients encounter when trying to access treatment at the community pharmacy level. And we'll go into a little bit of detail with regards to prescriber barriers, regulatory issues, and finally, impactful barriers that they encounter at the community pharmacy and what we can do to actually help them access that treatment. If you don't know, we'll get a brief introduction into what harm reduction is and how you can incorporate harm reduction modalities into your community pharmacy practice to help manage population health, as that is it's been an emerging and highly effective way to manage patients with substance use disorders. And finally, we'll have actionable steps by which we can implement strategies that increase access to substance use disorder treatment. And I just want to share a case vignette. Perhaps this is a patient that may seem somewhat familiar to you. I did, before I ever went into pharmacy school, I worked as a pharmacy technician for quite a few years and did some moonlighting afterwards. So I do recall practicing within a period of time when the opioid epidemic was certainly catching steam and folks were paying attention to it, but it hadn't caught fire the way it has now. And so it's interesting to see the change. And then after becoming a board certified psychiatric pharmacist, seeing the improvements that we can make and educating others by how we can implement those strategies for real change. So perhaps you've encountered a patient similar to this, a youngish patient who presents to pharmacies with a prescription for buprenorphine monotherapy, no insurance, willing to pay cash for it. As a good community pharmacist, you do your due diligence, you check their cures report, and you see a few prescriptions that are for full agonist opioids in the recent past. You look at the patient, perhaps you associate certain signs or symptoms for them that you may consider a red flag. Maybe they seeming to act differently from what you may expect. They're appear anxious or sweating or something like that. So Perhaps, this is something you've encountered in the past. I imagine this is something you encounter somewhat frequently, given the patient populations that we often encounter. So the opioid epidemic certainly doesn't need any kind of introduction. Unfortunately, we're at a point where we're setting records and not the good kind. So just in the past 12 months alone, the CDC has reported over 100,000 deaths. So this is the first time that we've crossed this six-figure threshold for overdose deaths. About 3/4 of those are due to opioids. And this isn't something that we want to downplay the effect of other medications. So a lot of what we'll discuss within this session is going to talk about opioids, again, because it makes up such an important part of these, real mortality that we see across the population. But we'll also focus on other areas where we can kind of improve, and certainly harm reduction modalities can be applied to all sorts of substance use disorders. I also want to point out that, especially on the West Coast, the methamphetamine related deaths are rising very rapidly. A lot of that is because of contamination and lacing with fentanyl products. So they're still opioid related, but they also have the methamphetamine related component as well. So it's not just patients seeking out heroin or fentanyl or other opioids that are unfortunately succumbing to overdose deaths. In addition to the significant impact that opioids causing on a population health level, it's also important to mention that excessive drinking costs the American economy about $250 billion. And you may think that a lot of this has to do with healthcare related costs, certainly ED visits, utilization for chronic comorbidities associated with excessive drinking. But a larger majority of those is actually coming from workplace productivity, criminal justice related costs, and so forth. So the reason we mention this is because treatment for these substance use disorders can potentially impact these broader social healthcare related outcomes, and not just strictly the healthcare related outcomes. So we do know that medications are effective at treating addiction disorders and arguably underutilized for how effective some of these truly are. So I'm really appreciative of having this session directly after Lisa gave her wonderful session on the soft skills associated with patients with psychiatric and substance use disorders, because I think setting those expectations and discussing the stigma that's associated with these patients is really important. So I won't rehash some of those topics that she already mentioned. I'll just highlight that the stigma that patients with substance use disorders perceive, it can be multifaceted. And so they experience stigma from public with regards to how people perceive addiction disorders. They perceive stigma from healthcare providers, including pharmacists, as we'll discuss, unfortunately. And patients themselves can harbor negative thoughts about themselves for having substance use disorders, and call that self-stigma. And any one of these alone would certainly impact the patient's ability to seek out treatment, to be engaged in treatment, and to have meaningful outcomes as a result of their treatment. So I think it's extremely important that, again, we use destigmatizing language, and we talk about this like the bona fide medical health condition that it truly is. And the reason that we can consider it a bona fide medical condition is we've learned a lot about addiction in recent years. We know that there is a physiologic change that occurs with continued substance use over a period of time. And this alters the way people can perceive the world in which they interact with. Of course, most of us can probably understand that with continued use of substances, you build tolerance to medications and substances that require higher doses to use. And additionally, that if you abruptly stop those, that we can experience withdrawal. In addition to that, I want to really highlight the intense cravings that patients with addiction disorders experience. And these persist well beyond the period of acute withdrawal, where folks with substance use disorders have these cravings that really make it so that they're unable to really focus on their activities of daily living, their social relationships, their work, and it ends up taking a significant toll on them and their productivity in life, because these cravings are just constantly affecting them. And so you can imagine just having something on your back that's constantly just kind of gnawing away and telling you to use something, even when the patients themselves know that it's causing harms, and they're not oblivious to these harms. And it's just this persistent thing. So really recognizing that these patients are not trying to, are not doing this out of a choice. It's a physiologic condition that occurred after the months and years of continued substance use. And I also want to highlight the importance of the patient's path to treatment. So we know substance use disorders, relapse is certainly a part of the disease. It happens, and patients shouldn't be punished for anything like that. And not all patients are necessarily ready to begin treatment. But let's just take the subset of patients that are. And if you look at the barriers, the patients who willfully seek out treatment and they encounter regulatory barriers that they may not directly be aware of. They encounter prescriber barriers, pharmacy barriers, and even pharmaceutical distributor barriers. So I'll talk about these in a little bit more detail, but the highlight I want to share is that you combine all these barriers, and after each one, you get fewer and fewer patients that are able to access treatment. And as we all know, pharmacy is kind of one of the last lines of defense that we have for patients. So by the time they get to you, I really want to highlight how many barriers they've already overcome. So let's start with regulatory barriers. And of course, most of us are aware that certain treatments for addiction disorders, in particular opioid use disorder, are met with particular regulatory hurdles. So methadone must be dispensed in an opioid treatment facility, so in OTP. And this is due to regulations that were set forth many decades ago that, as you all know, that if you were to treat a patient for methadone or buprenorphine in the community setting, and it was being used for a pain indication, these regulations don't apply to that patient. The second, these are being used for addiction treatment, there are extra barriers. So one, a community pharmacy won't be able to dispense methadone for addiction treatment. And when they do go to these OTPs, they actually have to present there every single day. So what we're telling patients, whether purposefully or not, is that they cannot be trusted with the treatment for a disorder that they have. It'd be like asking patients to come back daily for their insulin injection or something to that effect. And even buprenorphine, we look at the amount of training that a prescriber has to go through to be able to manage a panel of patients. A physician would have to go through 8 hours of training to manage a decently sized panel of patients. A mid-level provider would have to go through 24 hours of training for that. Some of those regulations have loosened recently, but to still be able to manage 100 patients or so, you still have to go through these. And again, that's telling the prescribers that they have to be extra cautious with this subset. When you're prescribing hydromorphone or buprenorphine for pain, the very same medications, you don't have to go through any extra, So again, we have these things that are not equally applied. And when you think about these, the treatment for a substance use disorder should not be harder to access than the substance itself. So these are just, some highlights of the regulatory hurdles that some of the patients have to go through. Additionally, we look at prescriber access. So at the end of the day, a patient has to find a prescriber. They have to prescribe the medication to them. And if we look at across the United States, there are 40% of counties that do not even have any Data 2000 waivered provider that can actually prescribe buprenorphine for addiction treatment. And of course, this, as you may imagine, impacts rural counties as well. But let's take a look at California, since this is the CRMC, and let's take a look at those providers that are waivered and they've undergone the training so they're able to provide treatment. And a recent study found that in a 15-month analysis, there was still about a third of prescribers who were not even actively prescribing treatment for any of the patients, despite having gone through X-waivered training. So again, that funnel, you can kind of see it narrowing in that there's a shortage of providers who are able to prescribe it. And then those that are able, there's still a third who either feel uncomfortable for one particular reason or another, or maybe are practicing in a facility that doesn't have the support to actually prescribe these. So there are still issues that patients experience there. And this isn't just a problem with opioid use disorder. We see this with alcohol use disorder as well. And again, this is something that's highly prevalent within the population. About 27.6 million adults in the US have a diagnosable alcohol use disorder. Only 9% of those actually receive treatment. So we have FDA-approved medications. I won't speak to the clinical efficacy of all of these. And, even as a provider within this setting, I can recognize some of the barriers to treatment. And they're not silver bullets. They don't cure the underlying alcohol use disorder. But if you look at it on a population health level, when you have tens of millions of folks with an alcohol use disorder, from a harm reduction perspective, you can certainly move the needle somewhat in terms of reducing some of those harms that folks are having from heavy drinking episodes, which again, a lot of these FDA-approved medications can do. And perhaps even engage folks into treatment and reduce the number of folks that die annually from alcohol-related causes as well. In addition, from prescribers, let's move on to the barriers that a patient experiences once they get into the pharmacy setting. So when prescribing isn't enough, we have a patient who's overcome the regulatory issues. They found someone who's ex-waiver to prescribe them medication. They found a prescriber who's willing to do it, and then they get to the pharmacy. And unfortunately, a lot of pharmacies across the country are just not well equipped at providing access to medications for addiction treatment. And unfortunately, we've seen this pattern. And my colleague Lucas Hill out of University of Texas found that less than half of pharmacies were actually willing to stock and dispense a buprenorphine product. Again, this is a bona fide medical health condition, and if we apply the same thing, we would think it's ridiculous if less than half of pharmacies stocked inhalers for asthma or insulin for diabetes. Yet when it comes to this, the majority can feel that it's okay to make that treatment inaccessible. This was corroborated as well with a national finding that was a little bit more optimistic, but still short of optimal, in that about 3/4 of pharmacies were able to dispense buprenorphine. And again, there's some difference in the methodology of these studies. So in the way you interpret these numbers, this latter one being more of a survey. So whether a pharmacy is able to dispense buprenorphine on a survey versus a secret shopper modality where you actually go in there with a prescription and say, will you fill this for me? It's a little bit different. We've also done an analysis locally that's currently in peer review, but I can tell you that even in high overdose zip codes in Southern California, we've corroborated these findings as well. So there are pharmacies that it's basically about a coin flip as to whether a patient will even have access to that medication, whether they're stocking it, let alone whether they're willing to dispense it. And if we even take it a step back from buprenorphine, naloxone, which is not a controlled substance, something that all 50 states have broadened access to it through pharmacies. We look at a recent analysis just last year that found that less than half of those pharmacies are willing to provide naloxone without a prescription, despite being able to do that. So at a minimum, I think we have to be sure that we're providing access to harm reduction supplies like the overdose prevention tools. I also mentioned
David, sorry, really quickly. I'm just wondering, David, can you hear me? Sorry, I think Bruno put something in the chat. He mentioned that one of the problems is drug access to wholesalers.
Well, a lot of pharmacists in the studies that assessed why they weren't dispensing medications or stocking buprenorphine for patients with opioid use disorders had a misconception that the DEA may cap the amount of buprenorphine that patients or that a pharmacy can stock and get access to. So just to clarify, the DEA does not impose any caps on quantities of controlled substances, including buprenorphine. one of these areas that may cause some confusion is that the Support Act and DEA regulations actually require wholesalers to develop a system for detection of suspicious or high volume orders. And this was a product of the extensive and multi-million dollar lawsuits that pharmaceutical distributors had during the height of the opioid epidemic in terms of their excessive distribution of full agonist opioids. Now, unfortunately, buprenorphine also falls under the opioid category, even though it is a treatment for opioid use disorder and arguably should not be lumped into the same categories as oxycodone and oxymorphone and hydrocodone, et cetera. Nonetheless, the DEA or the Support Act doesn't specify how pharmaceutical wholesalers actually implement this data or these algorithms. So what ends up happening, and I've got an excerpt here from the McKesson website, is companies end up developing their own proprietary algorithms for how they detect excess opioids. And within those conditions, you can see here, McKesson is very proud of their CSMP, which can include blocking the shipment of controlled substance to pharmacies when certain thresholds are reached. So again, this communicates to community pharmacies, if you order excessive supplies of potentially buprenorphine, which again, is a treatment, is a good thing, they may block that shipment and may cause additional scrutiny for that pharmacy, which of course all pharmacies want to avoid. Now, how do we address some of these issues? I'll always recommend, of course, advocating for those regulatory changes. And one of which is, of course, none of this can be done in a silo or alone. So joining organizations that help promote the effect of Xing the X waiver. So there is legislation in the Senate called the Mainstreaming Addiction Treatment Act, which will hopefully get passed, that will get rid of the X waiver and provide a stronger access to buprenorphine, including the ability for pharmacists to prescribe it under their own DEA license, as opposed to under a prescriber's DEA license currently. In the more short term, I mean, we can, of course, do the bread and butter of what pharmacists do and support prescribers in prescribing these treatments. So the dosing and drug interactions, helping prescribers with the treatments for substance use disorders that we don't have FDA approved products for, but just making them aware that there are treatment options available for substance use disorders, and perhaps to put them in touch with substance use disorder specialists, addiction treatment specialists, when their primary care physician isn't able or willing to provide those treatments. Because again, on a population health scale, in terms of the number of patients that our community pharmacies serve, we can make a really substantial impact by just plugging patients into medications that can help support their continued success. And of course, adherence support. So as I mentioned, relapse is normal. It's a part of the clinical process within substance use disorders. And so recognizing that and helping patients maintain adherence to these therapies is of course crucial. In terms of the pharmacy access, well, number one is to stock these medications and make sure that we're ordering it. I mean, certainly if we have full agonist opioids that we're stocking within the pharmacy shelves, we should also be stocking the treatments for those opioid use disorders. And be extra mindful of what you consider a red flag, because again, some of these symptoms, a patient may come in with anxiety, with sweating. They could be going through a withdrawal episode. And again, that's not a red flag for why you shouldn't dispense buprenorphine. In fact, that's an indication that, yeah, they're probably ready for buprenorphine and they need to get it quick. So recognizing that patients are already going through a lot with the management of these health conditions, that we shouldn't put extra barriers in front of them. And additionally, again, none of this can be done in a silo. So spreading the word broadly in terms of access to these medications is important. So let's talk a little bit about the practical pharmacy solutions. And this is a concern I've heard many times. Excess distribution, if I start a program, if I collaborate with addiction medicine providers in the area, I'll have the DEA on my back or the board of pharmacy or something like that. So what can I do proactively to help mitigate that? Well, number one is remember that all of this that we're recommending these are FDA approved treatments We're following evidence-based treatments for addiction medicine. So let's continue to be the most trusted healthcare provider and provide that access to those patients. Because none of these things are harming the patients. And so again, it's that when we impede access to the treatment, that can cause significant patient harms, that can have them, seeking substances elsewhere that can help relieve withdrawal, cravings, et cetera. Having said that, be sure to conduct the due diligence with patients. Obviously, diversion is a control. We'll talk a little bit. We'll talk a little bit more about diversion and how much of a concern it truly is when it comes to these medications. But I think there's a lot of reaction to the diversion risk of some of these treatments. And then finally, a proactive approach that I've helped coach community pharmacies through and even been a part of is actually reaching out to distributors, regional DEA managers, let them know that there may be an increase in legitimate prescriptions. You're starting a new program specifically targeting opioid use disorder treatment or stimulant use disorder treatment. Give them a heads up. You may see excess prescriptions. You can give them your policies and procedures if you've developed those clinical guidelines by which you'll be adhering to help them feel more comfortable with this. So that would be a proactive approach, letting them know ahead of time. And that's something that I've helped folks provide as well. Any questions on anything I've discussed so far? Great. So we'll move on to harm reduction strategies. And I think this is a really important piece and something that community pharmacies can really serve as leaders on across the country. So let's talk a little bit about where harm reduction came from in case you're not familiar with the history. So it really starts with when we consider the war on drugs, right? Back in the 70s, the Just Say No to Drugs campaign, that continued throughout the 80s. And all of these really followed more abstinence-based models for addiction treatment. They recognize that folks can become addicted to certain substances and set the bar that abstaining from use is really the clinical goal that we should be striving for. And while that's a reasonable goal for some patients, realistically, we know after learning about how addiction works within the brain, it's not feasible, at least not without some really significant help, interventions, and support. So, maybe a decade or two ago, we start to see things like this Onion article that of course, some great satire that says, the war on drugs is over, drugs win. And it's really, it really summarizes the extent of the issue with, that abstinence-based model, and that we're never going to stop, use of certain substances. It's a futile battle to try to win. So let's try to minimize the harms associated with continued substance use. And so what actually is harm reduction? It's a set of principles that involves meeting the patient where they are. And to do so, we have to make a couple assumptions, and we have to make a couple affirmations that we recognize that drug use is, for better or for worse, is going to continue, and that some folks are going to choose to use substances. And again, people have the autonomy to do so. Having said that, we know that certain practices are less safe than others, right? Sharing needles is certainly a riskier practice than using a sterile syringe every time. Likewise, testing your substances for fentanyl before you use them is safer than just consuming a substance and hoping it doesn't have it, right? So it's about finding that spectrum of harm and doing something about it. And we use harm reduction every day. Seatbelts are a form of harm reduction. None of us, anticipate being in a motor vehicle accident. But again, if we do, we're thankful that the seatbelt was there, wearing a helmet when you're riding a bike, using condoms, and so forth. So it's a way of reducing those harms, which can include infections from IV drug use or even overdose deaths themselves, which is, of course, one of the major things that we'd like to fix. And again, it really focuses on the quality of the individual and community life as the marker of success rather than abstinence. And if a patient is able to achieve abstinence, that's great, but that shouldn't be the only measure of success. So does it work? From the data that we've had so far and decades of implementing harm reduction programs, we know that it does reduce overdose deaths. It reduces infections, abscesses, risky behaviors associated with injection drug use. And you might think, well, does it increase crime, drug use, or needles in public spaces from all these fresh needles that you're getting out? And there doesn't seem to be any evidence to support that there is an increase in crime or drug use or needles in public spaces. But there is the reduction in all those other areas. So it does appear that this modality reduces meaningful population health level harms associated with drug use. So how can we implement harm reduction in the community setting? So these involve overdose education, naloxone distribution, clean syringe access, safe syringe disposal, safe injection education, fentanyl testing, and infectious disease testing. And we'll go into these in a bit more detail. Again, a huge role for community pharmacists especially is naloxone distribution. So in California, of course, pharmacists are able to furnish naloxone. There's relatively minimal requirements. And of course, you do have to label it, counsel the patient, and so forth. But again, in the grand scheme of things, not an overbearing amount of work. This legislation actually came first before the community distribution legislation that allows really community organizations to distribute naloxone. We've been able to do this at USC by having pharmacy students, again, so they're not licensed, they're not registered pharmacists. They're able to dispense naloxone. At Twin Towers Correctional Facility, we have a naloxone vending machine that patients that are released from jail are able to access. Libraries, schools, you name it, are able to actually distribute naloxone. And in some cases, that's better because it doesn't have the requirements of labeling and so forth that pharmacies are burdened with. There is still the education requirements on overdose education and so forth, and signs and symptoms of overdose. So that's still helpful. But again, even from a pharmacy perspective, most insurances will cover these. So again, it's a source of revenue. It's an opportunity to educate a patient from a trusted healthcare provider. Certainly at a higher level than they would get from, for instance, their librarian being able to distribute. Not to say that that's a bad thing. Any distribution I consider a positive. So again, these are easy things that we have access to and can implement relatively effortlessly. Syringe access. So California law allows really an unlimited purchase of syringes from pharmacies. They recognize that in addition for syringes being used for therapeutic purposes, that the provision of these services to reduce public health harms from injection drug use is also covered under this under these policies. So they're able to, again, provide that access. I've unfortunately encountered a lot of community pharmacists that are uncomfortable or unwilling to do so. Sometimes due to the legal ramifications of it, but again, no one has ever, kind of gone after someone for providing harm reduction supplies in this area. And again, just to reiterate, there isn't any association with an increase in crime or increased drug use. So when people have access to clean syringes, they're not, people that wouldn't have otherwise used injection drugs are not rushing out to, finally try heroin. That wasn't what was stopping them previously. So. The works, so people who inject drugs oftentimes have a kit for injection drugs, and that includes the works. And you may look at these supplies and say, hey, I recognize a lot of these supplies. It's because you can find them at many healthcare areas, whether it's an ED or even a community pharmacy. So things that folks can access, like alcohol swabs, syringes, sterile water, a cooker, which is kind of like a bottle cap where folks can mix their powder to prepare for injection. Again, providing that sterile water with these supplies helps minimize infection costs from using contaminated water sources. We'd certainly prefer that over LA River water. Vitamin C packets that help with the dissolution of the substances. Folks have been known to squirt lemon juice into their supplies to help increase the solubility. So again, this is a more sterile way of doing that. And these are supplies that are, certainly easily accessible for any healthcare provider. So providing harm reduction kits for folks, perhaps even seeking out grants that can support harm reduction kits, or even making them available for sale, could be ways that directly offer services that benefit patients out in the community. Safe syringe disposal, again, sharps containers, educating folks on how to create their own sharps containers, from detergent bottles and so forth, or even point them in the direction of Department of Public Health areas where they can safely dispose of syringes, and not to mention the large number of products that are available that can be purchased for patients to assist in the removal of those contaminated syringes. Fentanyl testing is another great harm reduction approach that is fortunately gaining a lot of steam right now. And essentially, fentanyl testing is the use of off-label strips that are typically used for urine drug screens. And you can use that to actually test substances for the presence of fentanyl. And this can be used for any powder, it can be used for a pill, it can be used with the residue found in a baggie. Obviously, the larger a sample you use, the more, the better it'll be in terms of making sure that you don't miss any potential fentanyl in the product, because as we're aware, fentanyl is very potent and it can have the chocolate chip cookie effect, where if you only measure a small portion of it, you might not actually get a fentanyl positive test. There is a variability, so there's a lot of these tests available. The gold standard right now seems to be these BTNX tests, because they've undergone sensitivity and specificity testing to ensure that they are accurate and available. And again, so this is something that we can help educate patients on how to use these test strips. It can be set up for purchase. They're relatively inexpensive, and given the high rise of fentanyl related deaths, can significantly impact overdose related outcomes. Another area in harm reduction would be the point of care testing. So this is available for CLIA waivered tests in HIV, hepatitis C. And again, this provides a great entry point for patients in terms of one, recognizing whether or not they have an infectious disease, and two, providing that access for treatment should they need it. And again, from my colleagues that practice in these areas, they state that we really don't have enough resources, enough community pharmacies that are serving as that point of care test site. The last area that I'd like to discuss today is that increasing access to these treatments. So again, in terms of proactive approaches, some of these we've already discussed, is low barrier naloxone prescribing, finding patients who have a prescription for opioids and offering naloxone to them proactively, rather than waiting for them to request it, waiting for their doctor to request it. Perhaps something that even at the health plan level can be recommended, finding patients with a morphine milligram equivalent, above 40, 50, again, trying to keep the barrier low to increase access to naloxone, because even though folks may have a low dose of opioids, they may, using them in conjunction with other CNS depressants could increase their risk of overdose. Again, if they have any street drug use, then that could increase the use, and that wouldn't be accounted for in their medication histories, of course. So low barrier prescribing, of course, patients have the opportunity to not request them if they don't want or deny it. So developing policies, evidence-based protocols to document these, would certainly help with that approach. Following up with patients on addiction treatment, asking the patient, hey, is it okay if I contact you in a couple of weeks? I know this is a new medication. Starting buprenorphine for the first time can be very different for their routine. So having that extra touch point really makes them feel that you as the healthcare provider really are committed to their health and well-being. And you'd be surprised how many times you uncover, yeah, I'm still having cravings, and maybe they're on a low dose that can be increased some more. Maybe they're having some constipation with the buprenorphine and really could use a lower dose. So there's a lot of opportunities for helping manage their medications rather than having them, get off of it. And I can't stress enough the opportunity to make relationships with addiction providers in the area. I work with a lot of addiction physicians and addiction psychiatrists who would love the opportunity to have a close relationships with pharmacies. I know that they often make lists of buprenorphine or harm reduction friendly pharmacies where they send patients because they've encountered so many of these roadblocks and barriers to pharmacies that don't provide these services, that there's really only a small handful of folks that can be trusted to help serve the patient. So I'd love to see that increase and that connection. We already talked about low barrier naloxone, so I won't talk much about that, but really I can't stress enough that low barrier threshold for getting into patients. Collaboration with prescribers. So California is of course unique in that the California Board of Pharmacy last year approved a CPA for pharmacists in their role in addiction treatment that specifically highlights buprenorphine as included within that treatment. They provide a draft CPA that can be signed by a physician and a pharmacist. And the impetus for that was really the initiating buprenorphine in the community setting. So you have a patient who maybe approaches a community pharmacy rather than an emergency department to begin treatment, perhaps while they're in withdrawal, as opposed to waiting until they seek out another substance and so forth. So being able to do that under the care of a DATA 2000 waivered provider, at least under the current legislation, is something that could provide increased timely access to buprenorphine. And again, these are national quality related metrics that are going to be a major focus in the coming years anyway. And of course, stocking it. So again, I'm oftentimes surprised, but from my experience, also not surprised by the number of pharmacies that just don't have these medications in stock. Making sure that we're stocking it, we're educating patients on these medications appropriately, and avoiding that canned response about controlled substances and the addiction potential when you're giving them the treatment for the addictive substance. I've seen that sometimes. So we don't want to unnecessarily scare patients, because certainly the addiction potential of heroin is a lot greater than buprenorphine. So I just want to go over a few kind of myths or concerns that folks sometimes have. So again, diversion or misuse of buprenorphine has been a big issue for why pharmacies may perceive that they can't stock these medications. But really the literature and clinical evidence tells us that the risk of misuse of buprenorphine is low. In fact, some studies have found that greater than 90% of individuals that actually buy buprenorphine on the street use it to reduce cravings and to reduce withdrawal effects. So when they're unable to reliably find heroin or fentanyl, if that's their drug of choice, they use buprenorphine to stave off the withdrawal effects. And again, this is perfectly within the realm of clinical practice. So, even though they're buying street buprenorphine, they're using it for a clinical indication that any addiction medicine provider would be happy to provide for them. So again, I think that speaks more towards the lack of access to treatment rather than the misuse ability of buprenorphine. And again, there's a lot of talk about the buprenorphine monotherapy versus the co-formulated with naloxone. The whole rationale for that I hear a lot of pharmacists and physicians say is that, oh, well, if you inject buprenorphine with naloxone, the naloxone will cause an immediate withdrawal effect. And again, will have a negative reinforcing effect on that. Again, the pharmacokinetics of that don't make sense. Buprenorphine has a much higher affinity. So it alone, if someone is tolerant to full agonist opioids, would cause a withdrawal effect, which is why we wait till a patient is already in a mild withdrawal before starting it. Again, I wouldn't get too hung up on buprenorphine monotherapy versus the co-formulated with naloxone. Sometimes I see patients request the monotherapy and people having an issue with that. Again, from a clinical perspective, it really doesn't make too much of a difference. And again, red flags. So this was pulled straight from the California Board of Pharmacy website. Nervous patient demeanor is considered a red flag for dispensing medications. the age or presentation of a patient, cash payments, long distances traveled, excessively celebratory demeanor. So, we have to be careful about what we're putting forward as our message, as a profession, because long distances traveled, we just talked about 40% of counties don't have a data 2000 waivered provider. If someone overcame the barrier and found someone who was able to prescribe, I don't care if they traveled 100 miles, and if this is the pharmacy they wanted to get it filled at, I'm happy to, oblige. And I hope my colleagues are as well. So again, cash payments, any number of reasons that could, explain that. But again, I just want to make sure that we're not too stringent on buprenorphine misuse as opposed to something like oxycodone or hydrocodone. So I'd like to go back to this little vignette that I posed earlier, and I'd like you guys to think about it. And so maybe if you've encountered this type of patient or this case presentation in the past, if you wouldn't mind maybe putting it in the chat, or perhaps some of our live participants would share what you have done in the past, or maybe what you would do going forward, seeing a patient like this, or just any thoughts that you have about it.
I would dispense it, right? But I have pharmacists who would not. And I can tell you that coming from the community where there was, Walgreens or CVS, where they worked for a number of years, when you have these patients coming from 100 miles away for opioids.
Mm-hmm.
It's like ingrained that this is kind of like the red flags that they were. So they would not. And I know that for sure for certain pharmacies. So if you're going to have increase in access from a pharmacy perspective, that has to change, and it has to change within the profession. And it's not just, we as a group here thinks, oh yeah, we can increase access, but those are not the people that are out there on the front line. So,
Yeah, I appreciate you sharing that. So if for anyone on Zoom who may have not heard, one of the participants would be happy to fill the buprenorphine for the patient, but is well aware of colleagues who would not, and are ingrained in thinking, well, this is an opioid, someone meets red flags, they got other opioids, they got other controlled substances in the recent past, they wouldn't dispense it. And so again, I really want to stress the advocacy and educating our colleagues for if we understand kind of the harm reduction approach, if we understand the access to treatment, you're right. There's an army of healthcare providers, not just pharmacists, who don't understand that, and so we really have to be very proactive on that. Someone else in the chat said dispense buprenorphine and give her naloxone spray too. Absolutely. So low barrier naloxone, even if they're on buprenorphine, if they don't use it for themselves, if they use it for someone else that they know, it's a win-win either way. There's no way a naloxone like that, is going to be a wasted product or anything like that. So again, clinically, I don't see anything in this Cures report that is not in line with the diagnosable opioid use disorder that this patient likely has, again, given that they're coming with a prescription for buprenorphine. Maybe they tried it before, had a relapse, and now they're ready to get back on. So it's an opportunity to educate the patient and give them another chance. So I think I'm just about out of time, but I just wanted to go through a few myths that, again, are so pervasive out in the community, that treatment is replacing one addiction for another. And again, I want to go back to, this is a bona fide physiologic change that occurs in the brain, and right now we don't have great options to really target the underlying pathophysiology of addiction. The best that we have is to minimize those cravings. Buprenorphine is great at doing that for opioid use disorder. Naltrexone is a great option to help reduce some of the cravings in the heavy drinking days with alcohol use disorder. but it's not replacing one addiction for another. It's using a bona fide evidence-based approach to reduce significant and real public health harms. Addiction is a choice. So again, we really have to recognize this is a medical condition. Having dealt with patients, if anyone has spent more than a few minutes, interacting with someone with an addiction disorder, they're not naive to the harms that it causes their lives. So they fully recognize that if they had the choice to stop, and then many people who would happily take that choice if it was available to them. So not that simple. And again, services that can improve access. So injectable medications, which are available that, again, help with adherence. So long-acting injectable formulations of buprenorphine. Again, there's REMS requirements, but long-acting naltrexone for alcohol use disorder. There's other medications in the pipeline that, again, we should be aware of. Delivery services, especially important for our patients that are experiencing homelessness, going out to encampments, and anything that we can do to help improve access for street medicine programs is going to be incredibly important, because oftentimes those patients don't have the ability to leave their tents or their encampment, all of their worldly possessions kind of in that one place. So, and contingency management was the last thing I wanted to mention. We talked about all the dollars that are floating into behavioral healthcare, substance use disorders. Here's a great example from DHCS. They're funding a contingency management program. For those that don't know, it's providing incentives for folks to either maintain abstinence from using substances or for harm. So, for instance, this is a payment schedule where a patient, for every negative urine drug screen that they have, they get a cash reward. So in this case, it's $10 for the first week, and they might have 2 appointments that week, so they would get a total of $20, and that progressively increases. And this might not seem like a lot of money, but contingency management programs have such a great track record in terms of being able to help patients with managing their substance use disorders and have terrific outcomes associated with them. And again, it can be used in conjunction with medications. Talking about any ways that we can kind of help incentivize patients to minimize harms associated with drug use. It's an opportunity to think outside of the box for what we've previously done. So I just wanted to mention that. And again, talking about looking ahead, advocacy efforts, the drug pipeline for addiction treatment, hopefully more options that will help treat the underlying causes as well. And don't forget those national quality metrics, having new patients start on medications and maintaining their adherence to them. So again, I thank you all for your time and participation, and I don't know if there's any time for questions, but I'm more than happy to take emails or any questions that you may have. Thank you.
Hi, everyone. We're going to go back into the main Zoom meeting link. Let's see if it's in the chat link.
His last slide had the link, so it was really good, but I don't know if they do.
Okay, so it's the link. It's the link that was. It's for the main meeting. So we'll see you all in there.
So law enforcement is perfectly allowed to do that kind of stuff. The first responders. You may have to differentiate what you get from a pharmaceutical distributor versus what they get from an autism distribution program. So I think that might help you because the wholesaler is obviously going to do that with the budget. Whereas if they get it from DHCS program, which they just applied for, it'll come. And that's how we did it at our school.